Well, hello, everybody. Is everybody here with us? Yes, wonderful. I am Jessica Durkee-Shock. It is my absolute pleasure to host tonight on behalf of the Early Career Immunologist Committee for CIS. This is officially the first meeting of 2025, and I hope that you'll enjoy the case that we have for you tonight. We're going to be talking about SOX1 haploinsufficiency and non-cirrhotic portal hypertension. It's going to be a little bit different than cases have been in the past. We're going to start off with Nadia Shobnam. She's one of our fellows here at the NIH. She is going to present the case. Then Dr. Kleiner, also from the NIH, I'll do a brief introduction in between, and he will present the pathology from the liver. And then finally, our hepatologist at the NIH, Dr. Rai, will talk a little bit about non-cirrhotic portal hypertension. Um, without further ado, Nadia, would you like to get started?
Sure. Can you hear me okay?
Absolutely.
Perfect. So I'm going to share my screen and get started. So thanks everyone for having me. I am excited to chat about this case. I am a third year fellow, like Dr. Durkee-Shock mentioned, here at NIH, and I saw this patient as a first year fellow, so bear with me. I'm going to present kind of the initial presentation, and Dr. Durkee-Shock will fill in if you guys have any questions about more recent findings. So, without further ado, here, the patient is a 55-year-old woman now who was initially seen at NIH in June of 2020. History was largely significant for a healthy childhood. She recalls having the occasional sore throat, strep throat, the occasional oral ulcers, but overall, until her 20s, was healthy. There was no history of severe infections in early childhood or hospitalizations. And then in her early 20s to mid 20s, she developed some autoimmune hemolytic anemia and some other autoimmune cytopenias as well. And then also around that time in her mid 20s, she developed recurrent sinus infections requiring two sinus surgeries when she was 23 and 41. And she continues to suffer from sinus disease to present day. So some additional history for her. Around when she was 40, she started to feel a little more sick. Occasionally, she noticed these periodic flares, she would call them, where she felt feverish, malaise, weakness, some oral ulcers that would resolve. And then she had quite a bad episode in 2012 when she was 42 that was fairly severe with fever, malaise, nausea, vomiting, what prompted her to go to the hospital. And during that visit, she was admitted and found to have diffuse lymphadenopathy throughout, cytopenias, including anemia, thrombocytopenia. GI imaging showed GI ulcerations at that time, hepatomegaly, and hypogam. During that, during that admission, she also had a bone marrow biopsy done that showed a hypercellular bone marrow, but the bone marrow was not concerning for myelodysplasia or malignancy at that time. And she improved initially with some steroids during that episode and unfortunately went on for further evaluation at Mayo, and clinically, she had a presumed diagnosis of ALPS and subsequently underwent a splenectomy around that period. We later found out that her genetic panel for ALPS was negative. And then because she was hypogam, she was started on IVIG around then as well. Her IgG before starting IVIG was 225. And unfortunately, we don't have records of specific antibody responses before IVIG started. And she reports that with IVIG, she largely had been stable for the next 10 years or so, with just like a few flares here and there that we'll talk about. But around 2021, she switched to sub-Q IG. So she presented to us in June of 2023, as we mentioned, with already her diagnosis of SOX1. So we'll kind of summarize in brief her initial lab work, and then we can weigh in on subsequent changes. So on CBC, She didn't have any active cytopenias when she first presented to us, and had a little bit of elevated monocytes. Her immunoglobulins were very stable on her regimen of replacement. She had a completely normal electrolyte and metabolic panel, normal liver function tests. She had normal CRP and ESR. We did an extensive autoimmune and autoinflammatory eval with a lot of autoantibody panels that were largely all negative. And then we did a pretty extensive PID flow here that showed normal numbers of T cells, CD4, TCD8, no elevated double negative Ts. And she did have elevated CXCR5 positive T follicular helper cells. And then for her B cells, they were low normal. And importantly, she had and continues to have low class switch and non-class switch memory B cells. And she also had some elevation in her CD21 low, CD38 low B cells, and continued to have normal NK cells. We did a cytokine panel and we follow her CXCL9, which is a marker of interferon gamma. And her levels have been variable. The very first one at NIH was 248, which would be not so high, but then she went up to 2400 during a flare episode. And the upper limit of normal for this would be around 647. And then for her cytokine panel, largely unremarkable, a little elevation of MCP1, inflammatory marker, and mildly elevated CD25, which, just was like 100 over normal. For her imaging here at NIH, just showed signs of diffuse lymphadenopathy throughout. And then her lung imaging showed some cystic change, some nodularity, and reticular densities. And then I should follow up. I think I may have a slide on this, but we did lung function testing, and that was all normal for her. For her first visit here, her 6-minute walk test had a mild DSAP, but subsequently we've repeated her 6-minute walk test, and those have been normal as well for her lung function. And then we're going to have our other speakers touch on her liver disease, but here just showing some dilated jejunal loops that we found in her GI imaging. And then of note, we did an MRI brain, which I don't have shown here, but so far we have not found any brain aneurysms or vascular malformations there. And then Dr. Rai will touch on her liver status, but we did do a FibroScan in October of 2023 when I saw the patient that showed some liver stiffness. And then at that time, though, she continued to have normal synthetic function of her liver with a normal CMP and no other kind of anomalies. So this is her sequence, as Dr. Durkee-Shock mentioned. She does have a heterozygous pathogenic variant of SOX1. And a little bit of her family tree. So the patient is here, and we have an affected sister with a nephew 1 here who unfortunately passed away at age 36 from sepsis after splenectomy for cytopenias. Nephew 2 was born with paniculitis and then has EBV positive diffuse large B-cell lymphoma. Nephew 3 was asymptomatic, and then she has a great niece as well with very early onset IBD and atypy. And then the father died with autoimmune cytopenias as well, and unfortunately of a brain aneurysm at age 39. So jumping into a review of SOX1, so the suppressor of cytokine signaling. So what does SOX1 do? As you guys can see from this diagram, it plays a key regulatory and negative regulatory role in the JAK-STAT pathway by directly inhibiting JAK1 and JAK2 and also TYK2 by the SH2 domain. And it also has an inhibitory role in many other pathways, the PI3K, the AKT, the mTOR pathways. It impacts IL-6 signaling. It is a very strong inhibitor of the interferon gamma pathway. So all that to say, it's a very important negative regulator. So when you have a deficiency of SOX1, you do see systemic immune dysregulation and overactivation of these pathways. So this paper goes into a review of 10 patients published that all had the SOX1 haploinsufficiency, and they all seem to have pretty significant autoimmune cytopenias, early onset autoimmunity, and lymphocyte hyperactivity, if you will. And again, some details of this cohort. So you see that they do have the Evans syndrome, like our patient did, early onset cytopenias. However, not a lot of very severe infections reported in early life, and that was also the case with our patient. And then just jumping to what we've been doing since we met her a couple of years ago. Initially, she was doing well, but she was found to have pretty significant liver disease. So we did start immunomodulating therapies for her. So we'll go into more details on that based on the liver findings. She's continuing on her IVIG, but we started sirolimus, and unfortunately, she did not tolerate this as it worsened her prior oral ulcers. We transitioned her to a JAK inhibitor, ruxolitinib, and she did quite well on this. But this was DC'd a few months ago in preparation for enrollment of a new trial with leniolisib for this condition. That if you guys have questions later, Dr. Durkee Shah can weigh in on that. So we're expecting her to start this soon in hopes that this would be a good immunomodulatory next step. And as a quick review, again, for SOX1, it's an autosomal dominant monogenic IEI that many of you have probably heard of. And you do see a lot of phenotypic heterogeneity so far. You see, autoimmunity involved in various systems, especially autoimmune cytopenias. You see profound immune dysregulation. This increased cytokine-mediated inflammation. We suspect some of these flares that she was having were cytokine flares, although with our testing, these things are tough to catch in real time. We see lymphoproliferation. We're seeing more and more liver disease and vascular disease, which our other speakers will touch on. And we do see hypogam. So just to end here, as we transition to talk about her liver, she has hepatomegaly. She has a stiff FibroScan. We're going to look a little bit in her path and talk about her liver function overall with Dr. Rai. But given all this, we can have some discussion on how worried we should be, and this has largely led to wanting to modulate her to some degree. So I can let the others weigh in on this as well. So I'll stop here and hand it back over to Dr. Durkee Shah.
Thanks, Nadia. So while Dr. Kleiner gets his slides up and running, because with these findings, the hepatomegaly, the stiff fibroscan, the dilated portal vein, even though her CMP was normal, our suspicion was high for liver disease. So she did go for liver biopsy here at the NIH. So Dr. Kleiner is a senior research physician in the Laboratory of Pathology at the NIH. He completed his medical school and PhD in chemistry at the University of Chicago. He is the head of histopathology and autopsy pathology, and he has a particular interest in liver pathology and inborn errors of immunity. Dr. Kleiner, thank you for joining us.
Sure. So I'm going to talk a little bit about the histologic findings in non-cirrhotic portal hypertension in general, and then we'll go to what this patient's liver biopsy showed. So non-cirrhotic portal hypertension is exactly what it says. It's the development of portal hypertension in somebody who doesn't have cirrhosis and often has no reason, no chronic liver disease that's known or can be diagnosed, but yet has evidence of portal hypertension. And this is basically a vascular injury. And in the literature, you will see basically three different forms that this liver injury takes. One is nodular regenerative hyperplasia, and I'll show you some examples of that. There's obliterative portal venopathy, where you lose the small portal veins. And then there's an entity called incomplete septal cirrhosis or septal fibrosis, which is it's a little bit difficult to define, and because some of the examples are actually regressed cirrhosis, so people who have been treated for their chronic liver disease and now the fibrosis is going backwards. But what I will show you are examples of these first two things. So first of all, characteristics of obliterative portal venopathy. In this situation, the portal veins are either missing or they're small. And so here are several examples that we published in the PASL recommendations for diagnosis and management of non-cirrhotic portal hypertension. And in these portal areas, it's really difficult actually to identify any portal vein at all. And that the portal vein should be about 3 times the diameter of the artery. And so in this portal area up here, that's the artery there, and that's the portal vein. And so you can see that it's really not that much bigger. So this is too small. There isn't really one here or here or here. And one of the other things that you can see then are in some of the larger portal veins is partial occlusion. So this these red cells here, these are smooth muscle cells. And first of all, you shouldn't have smooth muscle around the small portal veins. But in addition, you have all of this new connective tissue underneath that smooth muscle. So the normal outline of the vein should be out here, but it's starting to be narrowed. So that's also evidence of obliterative portal venopathy. The other entity is nodular regenerative hyperplasia. And you can think of this a bit like cirrhosis without the fibrosis. So you have regenerative nodules, which you can see best on this connective tissue stain, which is a reticulin stain, which outlines the reticulin that lines all the sinusoids. And you can see these nodules of hepatocytes. And here's one at lower power. You can see multiple nodules in this field. On the H&E, it's very difficult to pick up, but in some extreme examples, and this case here is the same as the one down here, you can see that there's congestion around the edges of the nodules, and sometimes that's useful. We have noticed fibrosis developing in some of our patients with nodular regenerative hyperplasia, although that did not happen in our case. And then over here in the upper right, you can see this is a CD34 stain. CD34 is normally an endothelial marker. It stains all endothelial cells in the body except for the sinusoidal endothelial cells. And then when you do see it in the sinusoids, what that means is you're getting a blood flow change. The blood flow that the sinuses normally see is a mix of portal vein and hepatic arterial blood flow. But in this case, there's more arterial blood flow than there should be. And so the sinusoidal endothelial cells start looking like systemic endothelial cells. And finally, these small hepatocytes in between the nodules are atrophic and take on kind of a cholestatic phenotype. So this is a keratin 7 stain. It's normally found in bile ducts. There's one tiny one up here, and normally negative in hepatocytes. But you can see that it's staining all the small hepatocytes around the edges of the nodules. So that's a very, sorry about that. That's a very easy way to detect these. Okay, so this is our patient here. And what we see here are basically abnormal portal areas. There's no inflammation, right? So even though this patient has a tendency towards autoimmune disease, we don't see autoimmune hepatitis here. There's very few immune cells at all, but the portal veins are abnormally small. They're kind of shunted off to the edge of the portal area sometimes. Here's another one, very small portal vein. And in order to make this diagnosis, you have to see this as kind of a consistent finding throughout the biopsy, because of the way that a two-dimensional cut goes through a three-dimensional object, sometimes you don't catch the portal vein. But if on repeated, looking at multiple portal areas, you see these small portal areas, there's not a good portal vein anywhere, then that's a clue to this disease. We did do a CD34 stain in this case, and it's also abnormal in obliterative portal venopathy, and you can see that a lot of the sinusoidal endothelial cells are positive, indicating that they're seeing more arterial blood flow than portal vein blood flow. So the diagnosis in this case was obliterative portal venopathy. There was this minimal inflammation and there was no fibrosis. So definitely non-cirrhotic portal hypertension. That's what we got.
Thank you, Dr. Kleiner. Really appreciate that. So now I'm going to introduce Dr. Rai because she and I have a problem. We have a patient with an inborn error of immunity. She is dysregulated, and she now has a pathologic diagnosis of non-cirrhotic portal hypertension. Dr. Rai will tell us a little bit about why that's a problem and then what we might be able to do about it. So Anjali is an assistant research physician in the translational hepatology section headed by Dr. Theo Heller. She received her MD from Boston University. She completed her pediatrics residency at Montefiore, and then she completed her pediatric GI fellowship at Johns Hopkins and spent some time doing her research down with us at the NIH. And then we're so lucky when she joined clinical. She has in inborn errors of immunity, and she sees all of the patients in the SOX1 cohort with me at the NIH Clinical Research Center. Thank you, Anjali.
Thank you. Thank you for that introduction. And thank you, Dr. Durkee-Shock, and to the organizers for giving me the opportunity to speak tonight. And so I'll be talking to you on non-cirrhotic portal hypertension because there's a lot to talk about. So I would like to define for you non-cirrhotic portal hypertension and help you understand the etiology of NCPH or non-cirrhotic portal hypertension and how it differs from cirrhosis. And then ideally, hopefully you will then understand the approach to NCPH management. So just a little bit of history. The concept of non-cirrhotic portal hypertension was actually first described a long time ago in 1870, and the actual term of portal hypertension was coined in English in the 1900s. And there's various terms that have been used in reference to non-cirrhotic portal hypertension. Nodular regenerative hyperplasia, hepatoportal sclerosis, idiopathic portal hypertension, obliterative portal venopathy, non-cirrhotic portal fibrosis, and most recently, portosinusoidal vascular disorder. Many of these terms you may have heard of before. But the underlying issue is that there is portal hypertension. And so you may recall, maybe in a high school physics class, that pressure equals flow times resistance. And so the flow of blood into the liver may meet resistance at multiple points, including prehepatic locations, either from portal vein thrombosis or splenic vein thrombosis, or posthepatic etiologies such as from heart disease or Budd-Chiari syndrome or IVC obstruction. And then for us, intrahepatic issues from either pre-sinusoidal, sinusoidal, or post-sinusoidal resistance. And so there's various etiologies from each location here. And it's important to understand this because that helps you understand the difference between NCPH and cirrhosis. So pre-sinusoidal portal hypertension is when there's resistance in the prehepatic area between the portal vein and the sinusoid. And the sinusoid is where the exchange of materials between blood and the hepatocytes occur. And so that causes of intrahepatic pre-sinusoidal portal hypertension include nodular regenerative hyperplasia, but also granulomatous lesions, primary biliary cirrhosis, and primary sclerosing cholangitis, hepatoportal sclerosis, and congenital hepatic fibrosis. And that's different than in sinusoidal intrahepatic portal hypertension, which is one of the causes is cirrhosis. And then there are post-sinusoidal etiologies, including veno-occlusive disease, central venopathy, and malignancy. And so just to make it clear, if you probably know already, but that portal hypertension can be divided into cirrhotic and non-cirrhotic etiologies. And so the risk factors for NCPH are very different than cirrhotic etiologies. And so they include genetic causes such as telomere disorders, developmental disorders such as Notch1, Turner syndrome, hematologic issues, as you can see here. Various drugs, including azathioprine, has been implicated, methotrexate, various immune disorders that you may know of already as immunologists, including CVID, hyper-IgM, XLA, and then various toxins that you can see here. So diagnosis is challenging, and we'll talk about why, including what the role is of hepatic venous pressure gradient, or HVPG, the role of liver biopsy, which Dr. Kleiner kind of already covered very extensively, and then non-invasive tests. So we talked about the areas of resistance in non-cirrhotic portal hypertension, and those include the pre-sinusoidal and the perisinusoidal areas. So in this diagram, what's really nice is that it shows that the splenic vein pressure and the portal venous pressure are about the same in non-cirrhotic portal hypertension. And because the areas of resistance are intrahepatic and pre-sinusoidal, when a balloon is dilated to measure the wedge hepatic pressure as part of HVPG, that actually only gives you measure of the sinusoidal pressure. And so that because of that, the HVPG is underestimating the actual degree of portal hypertension in these patients. So an HVPG of greater than 5 is considered elevated, and in these patients, the HVPG can be either normal or slightly elevated, maybe 5 to 8. And so our patient, actually, the HVPG was as high as 14. Her wedge was 17, and her free was 3, which is quite unusual. And so diagnosis tends to be a major component is liver biopsy, as Dr. Kleiner mentioned. And so on the left, I have a photo of obliterative portal venopathy, in the middle, nodular regenerative hyperplasia, and on the right is incomplete septal fibrosis. So there are various non-invasive measures of liver and spleen stiffness that many hepatologists use. FibroScan is probably something you've heard of before, and we'll talk a little bit more about that, but it does underestimate the degree of portal hypertension or stiffness, and it's not as sensitive. MRE, there have been many studies looking at liver and spleen stiffness using this modality, and it has been shown that as liver spleen stiffness, stiffness of less than 4.7, so not very high, and a ratio of spleen to liver stiffness of greater than 1.23 yielded a 97.6% sensitivity, 100% specificity, and a great area under the curve for diagnosis of NCPH. So MRE and MRE is a great tool to use. And it's important to understand that, as we saw with the pressures, that the spleen stiffness is often higher than liver stiffness. And here is a study looking at transient elastography, or FibroScan, in various cirrhotic etiologies compared to non-cirrhotic etiologies. And you can see a significant difference in the liver stiffness values. And these authors in this study noted a cutoff of 10 kilopascals with a specificity of 97% for diagnosis of non-cirrhotic portal hypertension. So the natural history of non-cirrhotic portal hypertension first begins with just positive liver histology. which can then over time develop into increased splenic stiffness, suggestive of portal hypertension, and then findings of varices on endoscopy or portosystemic collaterals, which is consistent with uncomplicated portal hypertension, and then portal hypertension with its related complications. And that includes ascites, hepatic encephalopathy, variceal bleeding. And so many patients in NCPH are actually quite asymptomatic, which is the case for Christine, or our patient. Nearly 70% of patients have large varices at presentation. And ascites, jaundice, and hepatic encephalopathy are actually quite rare. A small proportion of adults with NCPH may develop ascites, but that typically occurs after variceal bleed. And about 1/3 may have minimal hepatic encephalopathy. The long-term prognosis is actually better compared to those with compensated cirrhosis. And so therefore, these patients actually also have lower mortality, and that is also in the case of variceal hemorrhage compared to those with cirrhosis. However, patients with NCPH do have a increased mortality compared to those without NCPH, particularly in those with inborn errors of immunity. So in this study at the NIH, looking at chronic granulomatous disease patients, the graph in A is a patient who passed away, and you can see the significant decline in platelets over time compared to this patient in Exhibit B, who survived to the end of the follow-up period and had a relatively stable platelet count. And in this same study, they looked at declining platelet slope, the frequency of alk phos elevations, and the presence of abscess. And they found that the presence of all three was associated with a lower percent of survival. And when adjusting for alk phos elevations and the presence of abscesses, the platelet slope was still significantly associated with increased mortality. And so it's very important to determine whether non-cirrhotic portal hypertension is present in your patients with inborn errors of immunity, because it can provide prognostic implications. And so management is centered on management of portal hypertension and its related complications, neutropenia, sarcopenia, and quality of life. And I'll briefly touch on esophageal varices. And so endoscopy is recommended as surveillance for development of this. And so before the first bleed, primary prophylaxis, endoscopic variceal ligation or band ligation in patients with NCPH is recommended. And non-selective beta blockers can be used as an acceptable alternative. And so in our patient, she was found to have elevated HVPG, and because of that, we empirically started non-selective beta blockers. She, on her upper endoscopy, though, was not found actually to have significant esophageal varices. After the first bleed, acute variceal management is similar to patients with cirrhosis. And in recurrence, it's also similar to patients with cirrhosis, and tips may sometimes be used. Gastric varices, there are no primary prophylaxis recommendations at this time, but neither TIPS or shunt surgery is recommended as primary prophylaxis, but can be considered as secondary prophylaxis, especially in the setting of shunts. And this is our patient, and I just wanted to show that there was development of collaterals suggestive of portal hypertension in this patient. This was prior to her first endoscopy. And this is on her first endoscopy, and you can see kind of mosaic appearing appearance of her gastric mucosa, and that may be suggestive of gastric varices or findings of portal hypertension. And this is just a finding of gastric varices in an unrelated patient. And many of your patients, including the patient we're speaking about, do undergo splenectomy, but I think there is now literature to help us understand that splenectomy in the setting of portal hypertension is actually associated with significant risk of portal vein thrombosis. And so splenectomy alone, in addition to taking out an important component of your immune system, and in the setting of portal hypertension, is also associated with an increased risk of infection. So an alternative treatment modality is partial splenic arterial embolization, which has some benefits, including faster recovery, lack of need of blood transfusions, and so it is an attractive treatment, but there is a risk of splenic abscess. Liver transplantation is not typically performed in these patients because they don't tend to experience the complications of portal hypertension until very late. And you see these complications here. In those who do undergo liver transplantation, there's literature that has shown that there's actually recurrence of the non-cirrhotic portal hypertension, particularly NRH. So when to call your hepatologist, when you see findings of portal hypertension in the absence of clinical evidence of cirrhosis or hepatic parenchymal dysfunction, unexplained splenomegaly, patients with unexplained chronic abnormalities on labs or imaging findings, the presence of variceal hemorrhage without any evidence of hepatocellular decompensation. So with that, I'd just like to thank you, the patients, for teaching us so much. Dr. Theo Heller, my mentor, who has taught me so much, and Dr. David Kleiner as well, and Dr. Durkee Schock and the Nadia team.
Thanks so much, Anjali. So we have a couple of questions in the chat that I will field, and then, I would love to sort of open it up to questions and discussion. I think we all see these patients with NCPH in the setting of immune dysregulatory disorders in particular, and it's a particularly sticky wicket. So Harry Lasmata has a question in the chat. So how old was the nephew when he was diagnosed with lymphoma? And do you know what type of lymphoma he had? So he was diagnosed with lymphoma in his 20s, and then subsequently, and it was a non-Hodgkin's lymphoma. He had a diffuse large B-cell lymphoma that was driven by EBV. And then Anita Coley asked which genetic testing revealed the SOX1 variant. So I'm just going to quickly share my screen to bring back our slide that had the sequencing. So, of course, we work at the NIH where every patient that we see is on a research protocol. And so things are a little different roundabout these parts. So everybody gets whole exome, and then now actually everybody can also get whole genome sequencing. So this particular sequencing, if I can find the Zoom to share my screen. Here it is. So this particular sequencing was actually initially done on our whole exome sequencing platform, where this variant was found. And this was actually found prior to the initial Hajati paper in 2020. We initially found this, 2018, 2019. And the individual who is actually the proband is actually this person here, right? So we are talking today about this person, but he was the proband. He presented to us with an ALPS-like illness. So autoimmune lymphoproliferative syndrome. We were not able to find a traditional ALPS gene like FAS or FAS ligand. He unfortunately subsequently died of sepsis that progressed very rapidly as he was status post-splenectomy, and he was unfortunately not on penicillin prophylaxis at the time, although it is unclear whether or not that would have changed his outcome. So posthumously, we had done his, we'd reflexed his full exome sequencing to whole genome sequencing. And that is how we found this SOX1 variant, which was then subsequently published in the Hajati paper. We then did sequential testing in collaboration with Dr. Nick Hartog, who's the primary immunologist of this family in Michigan, to get everybody else sequenced, at which time we found the other individuals with this pathogenic variant. So I will, so other questions, and I encourage y'all, if you can, to come off and ask them yourselves, if you can. Yeah. Okay. Oh, and then so here I had another question. And this one's for you, Anjali. So what's the recommended interval for endoscopic surveillance for asymptomatic patients with NCPH?
Yeah, it's tough. Essentially once esophageal varices are found or portal hypertension is diagnosed, patients are started on a beta blocker, and after that, endoscopic surveillance is actually not required. So they remain on prophylaxis until they develop a decompensatory event, such as a bleed. And are there alternative non-invasive modalities? We kind of talked about the ones that are out there, which is just FibroScan, MRE, and platelet count, which is also a declining platelet count, may be suggestive of progressive portal hypertension. I hope that answers your question.
Any other questions? So from Lena, in patients with diseases with risk for non-cirrhotic portal hypertension, at what age would you start screening for the disease, and is an ultrasound enough?
I don't think there's a specific age cutoff. I think if there are any of the findings that we kind of mentioned, low platelet count, unexplained hepatomegaly, or even just small abnormalities on your labs, I would just recommend referring to your hepatologist. An ultrasound can help define some abnormalities like enlarged portal vein, hepatomegaly, but that alone is not enough to make the diagnosis of NCPH. So I'd recommend referral as soon as you suspect it.
Yeah, and I think that that's a lot of what you and I have come to together, Dr. Rai, as we see many patients at high risk for non-cirrhotic portal hypertension, both in the SOX1 cohort, and we co-manage a large cohort of patients with chronic norovirus infection who are also at very high risk of non-cirrhotic portal hypertension. And my threshold for calling Dr. Rai is extremely low. And as I said up front, she is now routinely sees all of my patients with SOX1 and primary immune dysregulatory disorders. And I think we have yet to find one that doesn't have an affected liver. I think our entire cohort of patients has had some amount of liver disease in the setting of SOX1. I thought I saw one more. So questions in the chat. So can you comment on portal hypertension as a finding of GVHD? And that's from Terry Harville.
They're not exactly related. You can have chronic graft versus host disease, and yeah, I wouldn't say that they're necessarily related. I think that requires like a
You
whole long
mentioned, I
discussion.
think, BOD. So as I think in that slide about, I wonder if that is where it's coming from, sort of the disease of VOD in the setting of bone marrow transplant. I'm not sure if that's what you're referring to.
Oh, so if that's the question, that you may recall is one etiology of intrahepatic portal hypertension, and that's a post-sinusoidal cause, which I know is very complex, but essentially VOD can cause portal hypertension.
So we have seen GVHD as a late complication of, uh, or seen NRH as a late complication after bone marrow transplant. I don't know that it's related to GVHD, just, maybe related to more of a microvascular injury or, slow chemo-related injury, same sort of thing that you would see in VOD, except without the acute presentation. I forget how often it showed up in our cohort of patients with long-term follow-up of liver disease after bone marrow transplant, but it did show up in a few. So it's something to consider if you're seeing unexplained elevations in liver enzymes long after transplant, maybe with these signs of portal hypertension. So
Um, so, uh, question from Nadia in the chat, and then I have a question for Dr. Wright and for others. Okay, so from Nadia, so can you speak more about norovirus and non-cirrhotic portal hypertension? She is a 5-year-old patient, and should he be screened? Either Anjali, you can field that one, or I can field that one. Or in fact, Dr. Kleiner, I'm not quite sure what viral studies you're doing for NCPH, given the recent findings.
I
I
mean,
guess like, oh, go
just
ahead.
quick, I have not seen this because as far as I know, we don't have any patients at the NIH where this has shown up and they've done a liver biopsy. So I'll let.
I'll dig them out for you. So there is an increasing interest around both autoimmune hepatitis, mostly T-cell mediated, as well as non-cirrhotic portal hypertension in the setting of chronic enteric viruses. So norovirus, sapovirus, and then the other one that comes up all the time is Aichi virus. And so there have been a couple of lovely papers coming out of Europe from Benedict and Nevin, among others, hypothesizing that these chronic enteric infections cause inflammation in the liver that then leads to variable pathology in terms of liver disease, both inflammatory hepatitis and non. We're still trying to sort of work this out, but Anjali, other statements to make about that association?
Uh, I guess I don't know the age of onset really of portal hypertension in a cohort of patients with norovirus, but I think any of the findings that we kind of discussed, if you have any suspicion, I would just prefer.
I think that, and right, that's been so tricky, right? Because we have so many patients with either completely normal liver enzymes, like she had, so her CMP was completely normal, or minimal elevations in ALK-Phos or GGT, and then subsequently we find actually a really significant amount of portal hypertension that hadn't otherwise made itself apparent. So is nodular regenerative hyperplasia also seen rarely with CVID and not necessarily associated with SOX1 haploinsufficiency? So I'll let Anjali, because we see it all the time, and Dr. Kleiner as well in our large cohort of IEI here at the NIH. So Dr. Kleiner, where are you seeing it? Because I feel like I see it every day, all the time, constantly.
Well, I think I have a fairly high pretest probability of seeing it because they only biopsy the patients who have, the potential for NRH. But I do, we have a big cohort and I see it a lot. But I don't think what I'm seeing is the whole population. So.
But I think we see it, I mean, I don't know your experience, but we sort of see it across the spectrum of CVID and the primary immune dysregulatory disorders. And Anjali mentioned the paper about chronic granulomatous disease. So really, I think it's any of the IEIs where you have, where you can run quite hot and dysregulated. I think it's sort of lurking underneath. Anjali, other things to say about that?
Yeah, no, like XLA, phosphoinositide 3 kinase deficiency, CGD, those are some of the common ones, here at the NIH, but ones that we tend to see it with.
Okay, so question from Lauren. Um, so what is the availability of these testing modalities, of course, outside of our facility? I think FibroScan has become pretty routine, but Anjali, you might be able to comment on that more.
Yes, definitely. In most adult hepatology clinics, the FibroScan is available, and they should also have access to MR elastography, and then platelets, very important.
Yeah, so but okay, so you brought up platelets. So my question had to do with platelets. So this family is tricky in that they all have SOX1. They all have some amount of liver disease. And we're about to biopsy another one in this family in just a couple of weeks. But they also almost none of them have spleens. And so we don't get the hypersplenism because they've all had their spleens out long before they developed liver disease. And so do you still see the trend in decline of platelet counts even when you don't have a spleen to sort of contribute to that sort of sequestration?
Yes, and so I think there's two things. One is the absolute value, which usually we see platelets of less than 500 in post-splenectomy patients who we are somewhat concerned about non-cirrhotic portal hypertension. And then also the trend is very important, aside from the absolute value.
So that's a pretty high cutoff. So you start to get worried about platelets under 500 in the post-splenectomy period, especially for these patients that have had, Evans syndrome. And so they lost their spleens sort of in childhood or earlier.
Yes, I think that, and then in the context of trend and imaging findings is kind of what we use to help screen.
Outside the NIH, I know that you and I talk about sort of that very subtle dilation of the portal vein that they often call on CTs at our institution. I think that is very helpful to sort of ring this bell. Is that also found? What is the level of sensitivity to that outside the NIH? I actually don't know.
Um, for non-cirrhotic portal hypertension.
Yeah, like just that finding of like the isolated dilation of the portal vein. Um,
I don't know the numbers off the top of my head, but I think it's just kind of maybe a poor man's way for us at least. One way we screen it, and it's not just that. The findings of collaterals, which we kind of I showed in one of the CT images, and then hypertrophy of the caudate lobe is also another finding, and then there's also nodularity, subtle findings you can see on CT.
Yeah, so to Lauren's point there about like what do you have available outside the NIH or sort of so the FibroScan, but then also, these subtle findings on just a random CT abdomen that you might get that might see that subtle dilation of the portal veins, or that might see just a little bit of varice, that then may trigger your brain to go down the rest of this path.
Yeah.
Okay, it's 5 of 9 here on the East Coast. And so I just want to spend a moment and thank our panelist, Dr. Kleiner, Nadia for giving us our case, Dr. Rai for being our expert hepatologist. I had been asked to prepare a brief journal club just in case we didn't have enough time or didn't have enough to talk about. And we ended up having enough to talk about. But I just want to call, since we've been talking about SOX1, I just want to call your attention to this paper if y'all haven't already seen it. Came out in Journal of Experimental Medicine, looking specifically at haploinsufficiency of PTPN2, leading to early onset systemic autoimmunity from Evans syndrome, including Evans syndrome and lupus. And the reason that I wanted to bring this to your attention, since we're having this conversation around SOX1 here today, is that here is SOX1 sitting as a regulatory protein as part of the JAK-STAT pathway, leading to the disease that we've been talking about here tonight. And here sits PTPN2. So this is the phosphatase that's supposed to go and dephosphorylate the JAKs, and so then sort of turn off signaling of the JAK-STAT pathway. It's also important for actually dephosphorylating after the transcription factors have done their job. And so if you lose activity of the PTPN2, you end up with this phenocopy of SOX1 to some extent. And so this was this lovely paper that had come out. And this includes, here, I'll just show you very quickly at the end, this comparison between many of our primary immune dysregulatory disorders. So STAT1, STAT3 gain of function, SOX1 loss of function, which is what we're talking about today, and these first group of patients that now have PTPN2 deficiency. So if you're bored and you have nothing to do later when you're trying to fall asleep, you can read about PTPN2. Thank you again. And with that, I will send you back all out to your lives. I really appreciate y'all. Bye-bye.